Good evening, everyone. Welcome to my Ed Talk. This evening, I will be discussing coagulopathies, describing the various types, pathologic versus pharmacologic, platelet etiologies versus coagulation factor, quantitative versus qualitative, hypocoagulable versus hypercoagulable, and inherited versus acquired, and providing a few examples of each. Jumping right into it. Pathologic versus pharmacologic. Pathologic is going to be something that's happening inside the body, and pharmacologic is something that is going to be caused by a medication that has been given to the patient. So pathologic, an example would be hypocalcemia, because lack of calcium calcium plays a vital role and it is required for activation of coagulation factors, as well as coagulation factor disorders, such as dysfunction, impaired cofactors, and deficiencies. Versus pharmacologic, which is going to be the intended or therapeutic result, like dual antiplatelet therapy, or an adverse result like HIT, or heparin-induced thrombocytopenia. All right, platelet disorders versus coagulation factor disorders. So an example of a platelet disorder, obviously it's an issue with the platelets. Is going to be thrombocytopenia, so a decreased platelet production or increased consumption or destruction. So lack of vitamin B12 and folate is going to cause a decrease in production. Versus a coagulation factor disorder, as I just mentioned, is going to be deficiencies of the cofactors, the dysfunction of the cofactors, or impaired cofactors. For example, factor V Leiden. All right, quantitative versus qualitative. So as the name implies, changes for quantitative, changes in numbers. So thrombocytopenia, a drop in the thrombocytes, versus a qualitative, change in quality or change in function, like antiplatelet and coagulation effects, and anticoagulation effects. Hypocoagulable states versus hypercoagulable states. So hypocoagulable, they're going to be an increased risk of bleeding, versus hypercoagulable, they're going to be at increased risk for clotting. So hypo is going to be thrombocytopenia, any deficiency of factor 5, 7, 8, 9, or 10 will lead to a hypocoagulable state. For hypercoagulation, for examples would be factor V Leiden or APC resistance. There is a triad, the Virchow triad, and so there's three things we're going to be looking for, which are decreased flow, increased viscosity of the blood, and vascular injury. Having these three things is going to put a patient at higher risk for hypercoagulation. And inherited versus acquired. So I'm sure, as you guys have seen, many of these deficiencies are caused by genetics or inherited or hereditary, excuse me. So von Willebrand factor disease, deficiencies of factor 5, 7, 8, 9, and 10, versus acquired, like, for example, uremic platelet disease, uremic platelet dysfunction secondary to renal disease. However, there are some that fall in both categories, like factor 2 deficiency or protein C deficiency. All right, I hope this was helpful. Thank you.